My name is Dr. Madhiha Abdul Kader. I am from Jinnah Postgraduate Medical Center, Medical Unit 3, Ward 7. The topic of my abstract is Correlation of International Normalized Ratio to Albumin Ratio with Mortality in Decompensated Liver Disease. The author of this abstract are Professor Syed Masroor Ahmed, Dr. Zishan Ali, and Dr. Mariam Bakar. Decompensated liver disease has a high mortality and morbidity, irrespective of its etiology. It is characterized by reduced liver reserves resulting in reduced synthesis of albumin and deranged international normalized ratio. Prothrombin time international normalized ratio and serum albumin both reflect the functional capacity of the liver. Abnormalities in these levels can lead to a poor prognosis in these patients. The concept of PT albumin ratio was used by Fang Gao on cirrhotic patient admitted in ICU for predicting the outcome at 90 days in a study conducted in China. He concluded that PT albumin ratio is a convenient and a practical method of predicting the prognosis of critically ill patients with cirrhosis. Not enough data has been collected so far to assess the validity of PT albumin ratio for determining the prognosis in decompensated liver disease. As albumin and INR are easily obtainable, these can be used as a tool to predict the outcomes in these patients. Objective of my study is to find the association between international normalized ratio to albumin ratio with mortality with decompensated liver disease presenting at a tertiary care hospital, to determine the association between PT albumin ratio with MELD score. Decompensated liver disease is defined as acute deterioration of liver function characterized by jaundice, altered mental status, ascites, hepatorenal syndrome, or variceal bleed. Prothrombin albumin ratio is defined as prothrombin time to international normalized ratio calculated as INR divided by albumin in grams per deciliter of the enrolled patients. Child-Pugh score is used for assessing the liver cirrhosis. It is calculated out of 15. It has two clinical and 3 laboratory parameters, and that include total albumin, total bilirubin, prothrombin time, ascites, and hepatic incaf. The method of the study is prospective cross-section study and duration is 6 months. Location, it was conducted at Medical Unit 3, Ward 7. This table shows the quantitative characteristics of samples with PT albumin ratio. The baseline characteristics are gender, cause of decompensation of liver, temperature, mortality, and Child-Pugh score. We have divided the patients in two groups: patient with low PT albumin ratio group and patients with high PT albumin ratio group. We can see that the patients in low PT albumin ratio group have increased number of subjects with grade A and B of Child-Pugh. However, in the high PT albumin ratio group, we have more subjects with grade C. In low PT albumin ratio group, we have a mortality. We can see a lower percentage of mortality, whereas in high PT albumin ratio group there is increased mortality. Although it is not statistically significant, but still high number of mortality is seen in high PT-INR group. We have an ROC curve that shows a diagonal line, and above which we can appreciate two curves. The green line indicates the MELD sodium score and the blue line indicates INR to albumin ratio. We can see that the green line has more area under curve, which is indicating that the MELD sodium score has high sensitivity and specificity. Although INR to albumin ratio and the MELD sodium score are closely related, but still MELD sodium score has more area under the curve. This is a scatter plot which shows that INR on the to albumin ratio on the x-axis and MELD sodium score on the y-axis. It shows that the MELD sodium and the INR to albumin ratio are positively correlated, but the relation is very poor. They are very poorly weak positive correlation is observed. The results are total 209 patients were enrolled, out of which 45.5% were male and 54.4% were male. Total mortality was 21%, out of which 59.1 were females and 40.9 were male. Patients were divided on the basis of low PT albumin ratio group and high PT albumin ratio group. The table 1 shows that high PT albumin ratio group has high increased mortality than low PT albumin ratio group, though it was statistically insignificant. 24.5% mortality is seen in high albumin ratio group compared to 17.8% in low PT albumin ratio group. High percentage of patients in low PT albumin ratio group have Child-Pugh score of group A and B. However, high PT albumin ratio group has more subjects with grade C. ROC shows an area under curve for INR to albumin ratio and MEL sodium score. Results showed that 60% area under curve was observed with 95% confidence interval considered statistically significant. Cutoff value suggested by ROC for INR to albumin ratio was 0.66 with a sensitivity of 55% and specificity of 53%. However, MEL sodium score area under curve was 61% and 95% confidence interval that was considered statistically significant. From ROC cutoff value for MEL sodium was suggested 17.5 units from ROC with a sensitivity of 58% and specificity of 55%. Scatter plots show a positive correlation between INR to albumin ratio and MEL sodium score. The correlation was 35.3% and R square showed that there was a 7.4% variation explained in MEL sodium score by the help of PT albumin ratio. The conclusions of the study is the PT albumin ratio is found to have a positive correlation with MEL sodium score, that is 35.3% in our study. Although it was statistically insignificant, high mortality was seen in high PT albumin ratio group. Therefore, multicentric study needs to be conducted at a larger scale to determine PT albumin ratio as a prognostic tool for predicting the mortality. Thank you.